Right, we'll call the October 17th Central District Health Board meeting to order. First item on the agenda is to approve the agenda. If there aren't any objections, we'll approve it by acclamation. Any objections? All right, agenda is approved as presented. Everybody have a chance to go through the minutes. If there aren't any corrections or objections, we'll approve the minutes by acclamation. Any objections?
No.
All right, the minutes are approved for the August 15th meeting. I don't see anybody, but good point. I rolled right past roll call. Corey is taking a silent roll call. That looks like we have a quorum. Now we can do everything we just did. I don't see anybody, but are there any public comments? Anybody? Seeing none? All right, very good. We'll roll on. We've got next on the agenda is a presentation about the audit from Mr. Zweigert. You have the floor.
Perfect. Is everyone? So I'm Jordan Swigert for Swigert, John and Associates. We did the audit for your year ended June 30th, 2023 and 2024. I'll briefly go over the audit report, kind of hit some high points, but if you have questions as I'm going through, please stop me. I'm more than happy to go into more detail. On the bound copy, I will start on numbered page 1, about the 3rd or 4th page in. As independent auditors report on the top with our letterhead. This is our opinion on your financial statements. What this says is we looked at your financial statements, we looked at the supporting document, tied out the balances, looked at how things are being classified in the system, and in our opinion, they are materially correct. Meaning at the end of the year, everything was recorded there, everything tied out to supporting documents, supporting the invoices, and what was there. Any questions on that? Perfect. From there, I'm going to jump forward to page 6. So your guys' financial statements historically have always been reported on a cash basis. That makes your balance sheet pretty simple. We just have cash. So you see at the end of 2023, you ended with just over $10 million total cash. And that increase at the end of 24, you were at $11.1 million total cash on hand. Down below, you can see most of that cash is restricted or committed. Restricted means that's like grants. A third party has said this is what it has to be used for. So in 24 of the 11 million, 4 million of that was restricted. It was set aside for specific things. Committed, the 6.6 million of it was committed. That means there's an entity, those funds are being held for a specific project. So it's not an outside person telling you, but inside you guys have said these is there. So if you take away all that, you had about $103,000 of that 11.1 million that wasn't either restricted in use or committed to something. So 11 sounds like a lot, but all of that is basically allocated for specific projects. Any questions on that? Okay, from there, I'll turn the page to page 7. This is your income statement for the year. So in 2013, you brought in just under $19 million. You spent about $16 million or increased your reserve by about $2.8 million. And then in 24, you brought in a little bit less. You were at $17.7 million of revenue. Expenses were up just a little bit, 16.6, but still the reserve increased by about $1.1 million. So both years there ended in the positive. Any questions there? After that are the footnotes. I'm going to jump forward to page 14. This just shows some of the long-term commitments that you have, some leases, some office spaces really you lease. I do have some operating leases. The payments for 23 were about $81,000, for 24 were $28,000 there, just for small equipment. But the bottom of page 14, those show the locations that you've already seen and what the lease payments were there for 23, and then turning to page 15. At the top there, those were your lease payments on that office space for 2024. Other than those leases, really, you don't have any other long-term, no debt, no other long-term commitments there. From there, I'm gonna jump forward to page 21. So in addition to just looking at the financial numbers that we kind of went over there, because you spend quite a bit of federal money, we have to do what's called a single audit. And that just means, in addition to looking at the numbers, we look at specifically how federal funds are spent and if they're spent in compliance. So page 21 through 24, this just shows all of the individual different federal programs that you operated and spent for the 23 and 24. So in total, you had, including non-cash expenditures for WIG and for vaccines, you had about $13 million each year in federal expenditures. So with that, jumping to page 26, these are our two reports because of that federal money. This one on 26, what this says is that in addition to just looking at were the numbers right, did they tie up to things, we also looked at controls over financial reporting. Really there, what we're testing is more than one set of eyes looking at everything. Are invoices being reviewed and approved before they're paid? Are time cards being approved and signed off on? Are the bank balances being reconciled to make sure that they're accurate? And in our test, all the samples we pulled, that was being done. So we did not have any findings there on those. And then similar on page 28, this one is specific to federal funds. What this one says, if we looked at a few of the programs to see, again, were controls in place to make sure that they were in compliance, or were reports accurate, and were they being reviewed, were funds being used for whatever that specific program was for there. And then looking at that and testing that, we did not see any issues. All the samples we looked at were accurate. We looked at WIC, we pull a sample of recipients. All the recipients we pulled qualified for WIC and were properly verified, everything there. So we did not have any issues to report there. Everything was in good order. Everything was there. So you can kind of see on page 31 is a kind of a summary here. So you can see the top says no issues or no reported no. So there were no findings, nothing to report there. One thing I'll just point out, the very last one says, does auditee qualify as a low risk auditee? And it's no. You'll always be no because you report on a cash basis. Just by federal reporting single audit standards, unless you do financials on a full GAAP basis, you can't be a low risk auditee. So that note has nothing to do with that you had findings or that you're doing things wrong. It's simply you just report on a cash basis. So it just has to be no. But that doesn't affect anything really. I know that was a whirlwind of numbers and information there. But any questions for me?
Sure. On page 10, on the unrestricted net position,
Yes.
it said, sorry, it gives the numbers for 23 and 24. Is one of those supposed to be unrestricted there on the bottom of that last sentence?
Issue was.
For the unrestricted and restricted.
Yes, you are correct. That should say unrestricted.
Okay, I
Yep,
was like,
I apologize. Yep.
I didn't know if the numbers were flipped or, okay. Perfect.
No, that should say unrestricted. Yeah.
I was just read it and I was confused.
And that unrestricted number is bigger than the, when I looked at it, I said it had the 103 that was. So government statements have to report in two separate ways. One, you have net position, the other you have fund balance. For you guys, they're the same because you're cash basis. But for net position, we can't show committed funds. the fund balance, that's why where we got the 103 is we pulled out the committed portion of that, which for the net position we can't show. So that's why the fund balance is a little bit more accurate for you because that shows what you guys internally have committed to specific projects. No, very good question. Thank you. Any other questions?
How big is the sample that you take to come up with the?
So, I mean, everything's different. Normally in each category, we look at least 60. I think, top of my head, I don't know, but for like WIC, we pull 60 to 100 recipients randomly to look and say, were they validated correctly? Did they qualify? On the expenditures, we pull about 60 just random expenditures, and then we pull in different areas some more for specific items that we're looking at.
60 of how many?
Like expenditures
Right, but
of
how many?
invoice.
Like, what is there a percent?
The participants are about 6,000, about 10%.
Yeah, sorry, I don't know the total population. Yeah, just normal is about 60 per year of the total population. And if there's no issues in that random, then we're pretty good. And then we normally look at anything else in a little bit more detail. And if in that initial poll there's problems, then we expand.
Well, that was my question. So does anyone else have any other comments, questions about the report? Well, very good. Well, thank you for joining us in your time.
No problem. And then you'll just want to, I didn't see on the agenda if it was an action item. If it is, you'll want to make a motion to accept the audit report. If it wasn't listed as an action item, you'll want to just do that at the next meeting, to accept the audit report.
Okay.
And we talked with Conan about going forward, if you want to do it, to change from doing a biannual audit to doing an annual audit. It just allows you guys, looking at 23's numbers now doesn't provide you a lot of forward-looking opportunity to make decisions based off that. So that's why we kind of suggested doing an annual audit that gets you the information a little bit more timely so that you can make changes if needed, more timely basis.
Is there a fair amount less work to do it on an annual basis from your point of view as opposed to a biannual?
Yeah, we find there's a little less work because we're not having to test both years. We would test just 1 year. And we also find that it's easier because when we're asking people what happened and we're saying what happened 2 years ago, it takes longer to gather that information, to figure it out, to remember, where if we're saying, hey, what happened a year ago, it's a little bit fresher on everyone's mind. So from that aspect, it's simpler as well.
You put that on the December agenda along with accepting this audit, and y'all can decide what you want to do that. Does that sound good?
Sure.
Yeah, and I believe, Conan, I sent you an engagement letter with the pricing on that and everything too. So he has that as well.
Very good. Thanks again.
Thank you so much.
Thank you.
All right. Next on the agenda is our financial review with Laurel. You have the floor.
You should have Jordan and the report he provided, and Conan and I do support going to an annual audit as well. So when that comes up at the next meeting, so you have that. I think some of our federal funding partners, some require an annual audit, not any funding streams that we're receiving now, but as we look at new grants and funding streams, some of them do have that as a requirement. Often it's a softer requirement than some of the other ones, but it just gives us a little bit more flexibility on what kind of funding streams we're looking for, in addition to being easier, as Jordan pointed out. A lot of more in December. Okay, so this report brings us through the first quarter of the fiscal year, seeing similar things as we normally do at this point in the year. There are a couple of good things that I will point out as we go through the report, but revenues are coming in at 30% of budget, even though we're just at 25% of the fiscal year. So That's good. Our fees are looking great for FCS, coming in at 38% of the amount that we plan to receive for the entire fiscal year. So that's a positive trend compared to where we've been for the past couple of years, fiscal years. Our community environmental health fees are coming in at just 19% at this point in the year, but those aren't cyclical. We get a big bump in our CEH fees over the next few months because our renewal season is upon us. We'll be sending out the letters to all of our food facilities for renewals here in the next few weeks and beginning that cycle of all of the food facility fees coming in. Our support services revenue, that's another one that looks like it's off quite a bit from what we planned for the year, for the entire year. That came from selling vehicles, from building leases, and we also received a refund from a vendor. So we're at 125,000 there, where we plan to be at just 47,000 for the whole year. And good news, because our vehicles sold for more than we expected, and getting the revenue from the vendor as well. So good things there as well. Our county contributions and interest revenue are where we expect them to be at this point in the year, which brings us to that total of 30% of our revenue for the year so far. For expenditures, we're really close to our planned amounts in most of our categories. As we saw last year, even though it was just 1 month of the fiscal year, our support services operating continues to be higher than planned, mostly due to IT costs. And I think that's something we'll look at over the next couple of years when we're putting the budget together. Both of the last 2 years, our IT costs have been higher than we planned. So we may need to just look at what we're planning for that. So we're not over, it's not putting our whole budget over where we plan to be, but it always is off in that category.
Laurel?
Yes.
Going back to the refund from the vendor, what was the circumstance?
It was a CompuNet payment, so they're our biggest vendor that we use for IT. It's a $70,000 refund payment, and I think it had to do with timing of when it was billed, but I can find out from Conan exactly what it was for and get that back for the December meeting if you need.
I'm just curious if it was like services that were overbid or, a prepayment that.
The services happened last fiscal year, but we didn't receive the bill for this year, so we paid it and then reallocated it to the right year. But I'll make sure I have it correct and just do at least send you an email or let you know for sure.
Okay, thank you.
Mm-hmm. Okay, so back to the report, trustee and benefits are behind planned amounts. That's another one that's not cyclical, so it's not unexpected to be off of, for the percentage not to match where we're at in the fiscal year. And overall for expenditures, we're coming in at 26% of our planned expenditures at 25% of the way through the year. So very close to where we want to be there. That leaves us a gap of about 4% between our revenues and expenditures. So that's something we'll pay attention to. Usually as we progress through the fiscal year, it gets closer to 8 or 9%. We're really trying to keep it to no more than a 5% gap this year. So we'll keep talking about that at board meetings and looking at where that is. Moving on to page 2 of the report. This is our year-over-year look at the budget. And as you can see, the fees in both community and environmental health and family and clinic services have increased compared to the last 2 years. If you recall, for our FCS fees, the last several board meetings, we've been behind in our fee reporting and making sure that they're allocated to the right categories. We're now completely caught up and anticipate that we'll stay that way. It just had to do with new staff member training and making sure that they knew everything they had to do and knew how to do it into the right categories. So we're there now and should stay that way. And on this page, you can see a better breakdown of those family and clinic service fees. We expect those increases to continue. I did want to follow up from the last board meeting. We had talked about the fact that at the end of fiscal year 25, our reproductive health fees were down. And I wanted to follow up on that because I looked at the why behind that. So looking at our reproductive health appointments in FY24 and FY25, our number of appointments, total number of appointments stayed about the same. There was a little bit of an increase, from FY '24 to FY '25, but the big change was that we put almost twice as many people on a sliding fee scale. So that means that our customer service reps are doing a really good job of making sure that when people come in, they make sure they're getting onto the right plans and getting billed appropriately. So to see that double is reassuring for me to know that we're asking everybody when they come in for their income statements and making sure that they're being charged the right amount and paying the right amount. So it caused the fees to go down overall, not from a reduction in the number of appointments, but because we're doing a good job at intake of making sure they're charged appropriately. And then back to the report, our contract amounts are down from the last 2 years. And most of that was planned. We knew it was coming. That has to do with the loss of the COVID-related contracts, both COVID immunizations and the COVID CDC contract, Title 10 and Title 5 funding in the clinic, and then Ada County ARPA ending as well. So you can see it's a pretty big reduction from where we've been over the past couple of fiscal years, but for almost all of that, we knew that they weren't going to be coming in this fiscal year. So for our total revenue, the bottom box there, for both fees and contracts, we're a little bit over our planned amounts, and that's just because we knew the reductions were coming in the contracts and fees are above what we planned. So that's included in the budget already. And then for personnel costs, we're a little bit under, as we talked about on the first page. For operating costs, we're over. Our TMB is behind, and then our capital outlay, just to bring attention to that really quickly, we're showing that we're 77.3% over at this point of the fiscal year. We only put $25,000 into our capital outlay budget for this year because we planned most of our capital projects in special projects. So we had a really reduced amount in our general budget for capital outlay, and most of that shows up in our special projects. So when you see that one's off, we're talking a pretty immaterial amount overall. It's just a big percentage because it was such a small number to start with.
Laura, up here, would you remind me again, under operating the budget, we're over 30.2%.
Yes, so that again goes mostly back to the IT costs that are coming in. When you look at it on this page, it's different numbers that are used for the percentages. It's from the total amount rather than where we're at the point in the fiscal year, which is on page 1. So sometimes the percentages seem bigger, smaller based on that, but it's not anything I think we need to be paying too much attention to at this point. We're still coming in at 26% of our planned expenditures overall when you look at the big picture.
Right. Thank you.
Right, and then moving on to page 3, our cash balance statement. And this goes along with what Jordan was just talking about. So our total cash balances were really high, coming in at 12.2 million. And as he pointed out, most of that is restricted or reserved. So reserve fund designations are 7.6 million. Our restricted funds are 4.6. And thought he did a really good job of explaining what comes in as contract or federal funds that's restricted to specific activities, and then what we internally have decided we're allocating to activities. That's the difference between the restricted and reserved. So great way to sum it up. That leaves us a negative undesignated unrestricted balance for this month's report of 28,000. We've seen that fluctuate over the past calendar year of being a little bit under to a little bit over, but that's because we have so much set aside for specific projects. By the next meeting, it'll be back into a positive. It doesn't really mean we're out of cash or don't have money. It just means we've got it in our set aside accounts. And then quickly, before I wrap up, updates on our special projects and carryover designations. So we did finish the McCall facility refresh. We are going to have some pictures of that for the next board meeting so you can see the before and after. The bills haven't come in for it yet, so that's why it still shows negative on the report, but they will show up by the December meeting as well. but it looks great. So thank you again for your support of that project. We also finished the roof project in Mountain Home, so I'll have pictures of that before and after as well. Not, the roof's not as impressive as the internal of the building, but.
More important.
But more important. Right, yeah.
Impressive, but
And then program support, we've begun spending that down, and a little bit of the CDH staff money that we had set aside as well has begun to be spent down. Not any big movements there. We'll be meeting with the program managers who are responsible for these special projects and making sure they have plans to spend this down also before the next board meeting. So I can give you a more comprehensive report on that. The only other update that I wanted to call attention to on our special projects is our Excel continuation, our EHS system that we have been working on for years. We are looking at that go live date in March, we think. We don't have the specific date yet. Curtis and I have been meeting with them regularly and have another meeting next Tuesday. Our staff have been doing validation of the system, so they're in the build that they've made for us. They're making corrections to make sure that all the fields are on the right pages and representing things correctly. The next step for us will be to see what the reports and the outputs of the system look like and make sure that matches what our customers are used to seeing and that basically matches what we're providing now. And then we'll do one more set of validation and work on what our actual go live date is and the training that goes along with that for all the staff. Right now, it's been a smaller group of just subject matter experts that are doing the system validation and that kind of thing. So Chris and I are working on the communication, the change management for it, and making sure that we have a full training plan in place so that it's hopefully a smooth rollout once we get there. And that is all I got.
Right, very good. Any questions for Laurel before on? None? Very good. Thank you.
Thank you.
Next on our agenda is a director's report regarding the DEQ understanding.
Thank you, Mr. Chair. So we had brought this issue to the board in February. The challenges our staff have had with non-municipal solid waste sites, specifically private businesses that are not your typical simple operations. They involve recycle facilities, industrial waste facilities, and the board was agreeable to starting discussions with DEQ to see if there was a way for us to continue doing inspections on non-municipal solid waste sites that are county-owned transfer stations. And as those of you who heard Director Burns speak yesterday, it's just, there wasn't a real good explanation why transfer stations are classified as non-municipal solid waste sites. And I think the Idaho Solid Waste Association is planning to get that clarified, which I'll talk about here in a second. So as the months went on and communication with DEQ administration, finally got to the point of, well, there's another complex non-municipal solid waste site coming online in Ada County, and of course our staff were like, are we going to be involved in approving the operating plan, which means we give it to DEQ because we don't have the technical expertise, and then they give us feedback for us to ultimately approve those plans, and then we're responsible for the oversight, which also requires a lot of interaction with DEQ because they have the technical expertise to do that. So in August, it was shared with you all, it was DEQ's response was for non-municipal solid waste sites, it's all or nothing. So you're either going to do the complex and the transfer stations or none at all. And you all agreed with it. They won't allow us to continue to do the transfer stations, then we're going to have DEQ do that. So I actually met with Director Byrne and some of his leaders early in September and just talk through this and explain, here's what's coming from Central District Health. And at that time, interestingly, 6 of the 7 health districts were on board with going down this path. District 3, for whatever reason, they were going to continue to do non-municipal solid waste sites. When it came time to send the letter, knowing that the Idaho Solid Waste Association is planning to take the public health districts completely out of the responsibility for solid waste, municipal and non-municipal, they were like, well, we'll wait and see what happens with that. So this went from me to Director Byrne. We're out of non-municipal solid waste sites. We would like to continue, our preference is to continue to do non-municipal solid waste site transfer stations. But you understand you're not agreeable. So that I sent the letter on the 18th and 30-day notice, October 20th. So next Monday is when we're done. And I think my preference was to give a longer notice, but they basically had notice since last February that this is the path we're looking at heading down. And also the timing on it complied with the MOU under 30 days, but the operating plans are in the queue to be reviewed for the one I mentioned that's going to be coming online. And there's no point in us starting doing that when we know we're not going to continue to do this work. Also, important to note is we are by law required to do municipal solid waste sites, but not non-municipal solid waste sites. And that dates back before my time here. Why did we even agree to do that in the first place with no money, no revenue coming in? We didn't charge fees. DEQ doesn't pay us to do it. I'm not sure why that happened, but yeah. So that's the update. And as I mentioned, the Idaho Solid Waste Association, this legislative session is planning on changing Idaho code such that the health districts no longer have any involvement with municipal or non-municipal solid waste work. The big challenge is, as Director Byrne noted, is they don't have the staff and they don't have the money, and now their budget's being cut ongoing by 3%, and trying to figure out how to fund that. So they're talking about tipping fees and different means to generate revenue for them to do the work that the health districts have been doing for free. It's not for free. The counties are paying it now because we're no longer funded at all by the state from a general appropriation. So that's the update.
Who knew trash could be so complex?
Yeah.
I have no idea. Some tires.
Yeah, you and your Elmore County tire pile.
Can you get more so?
Right, very good. Any questions for Russ on Jack Garbage?
Can I take just a moment and introduce one of our newest managers?
Sure.
So I'd like to introduce Jamie Butler Dawson, who is our communicable Jamie. Yes. Communicable
Not like
disease
Jaime.
and managing our communicable disease and epidemiology program. So I'll give you just a second to introduce yourself.
Sure. I'm excited to be here working with this great team at CDH. I've been in public health for over 20 years. I'm an Idaho native. Went to Bora High School and I played volleyball at NNU. And then I've been gone for 20 years. So I've got my MPH in public health and my PhD, and I've lived abroad with the CDC, working with the US CDC in Kenya. I was in academia for over 7 years as an assistant professor, teaching at Colorado School of Public Health and doing field research. So excited to be here, and it's nice to meet you. Welcome.
Good to have you. My little sister played volleyball at NNU for a stretch.
All the time.
I don't know. She's the little sister, but she was there. All right, very good. Then we are going to have a little conversation about the association annual meeting in the last couple of days. So I don't know, Russ, maybe if you would want to offer a couple of takeaways. I know the only thing I really regret is not wheeling this chair in there for 2 days.
You could. Yeah. Well, so my takeaway is that I've been attending these meetings for 20 years now, is that we always have the education day, which was the first day, and that's decided by the host district. This year it was Public Health District 3. And the theme was around basically child abuse, sexual exploitation, and the challenges that Idaho has with that. Sex trafficking heavily, as far as the percent of individuals sex trafficked, it's shockingly high for minors. And then included was the commander over the, it's ICAC, but I can't remember what that acronym is for, but basically they do all the investigations and sting operations for individuals who are engaged in these activities. And it's fascinating to me, the challenges they face because of technology, that a lot of the bad actors are not in the United States, and trying to figure out how to arrest and prosecute is really challenging. Although I think it was the last 5 years they've successfully prosecuted, I think, 141 people here in Idaho, which was good to see, including one the night before in Nampa. So I don't know if that made the news or not, but that's good to see. That there's a lot of through the Attorney General's office and through local law enforcement. So the next day we had the directors and a person talking about just healthcare in general and the challenges with Medicaid, the changes coming up with Medicaid, the loss of the premium tax credits with the Affordable Care Act, and the how that's going to shift more costs to individuals, and likely we're going to see a much larger uninsured population, which my interpretation of that is people will go to the emergency rooms for care or do without if they can, or they're of that mindset. So then when we do resolutions, which this board brought 3 resolutions and 1 position statement forward, there was only one other resolution that was converted to a position statement when it was presented. And that one was from District 6 to have the health districts essentially continue with clinical services. There's discussions among some boards to discontinue offering clinical services. Laurel talked about the our sliding fee scale and the things that we offer to our patients, and how we're doing a better job at that. And we're serving individuals who, if you go to FQHCs, they typically have at least a minimum fee. There are costs associated with labs and things that we can cover for patients who simply can't afford care, and that's why they come to us. So I appreciated that resolution. It was changed to a position statement because it's not a policy. There's no policy decisions that have to be made or legislation around that at this time. Who knows what might come down the road. Our resolutions were to affirm that 3801, which is a law that allows minors 14 and older to consent for their own care around infectious and communicable diseases. So that I don't know what to say. It was a hard discussion for me to listen to because we talked a lot about parents' rights. In fact, it was the Parents' Rights Act that caused that to be undone. So when a minor comes to our health district, or Full Circle Health, or Desert Sage, or St. Luke's, if they don't have parental consent for any type of care, but for communicable diseases, they're turned away. So I did my level best to convince the group that given the fact that chlamydia, for example, for females is 70% of the time is asymptomatic, it seems like a good idea that we ought to be ramping up our efforts, not going the other direction and doing more routine screening based on risk criteria, you know, new sex partner, 3 or more partners last year. There's guidance out there for healthcare providers to do that work. And the consequence is, and will be, no doubt about it, we're going to see more chronic health conditions, pelvic inflammatory disease, chronic pain, infertility, and kind of that list goes on. So I was ultimately what happened with that was it was modified. I'm not real clear on what the outcome is. I guess we'll see what the minutes reflect. We're going to ask the legislature, hey, did you really mean to do that? But not in a way of all this bad stuff can happen if we don't do this work in Idaho. And what I heard was parents' rights are more important than long-term health for a decision a 16-year-old makes. So I would like to hear more from this board. I'm like, okay, what do we do now? What do we do with that besides get clarification, which I have an idea what that will be, without some type of, like, hey, here's all the data and here's the facts, here's what we're seeing. And Jamie was kind enough to put together some data for me ahead of time that really tells a story that in the last 5 years, we've seen a decline in reported cases of chlamydia among 14 to 17-year-olds of 67%. So you could draw one of 2 conclusions. That's great. We have less chlamydia in our state. Don't know why that just happened. Or we could say, we're not testing anymore, and we're going to have a problem, a public health problem, shortly. So the other resolution was, of the 2, was on to reestablish the public swimming pool rules and give the health districts the authority to do that. And same thing, I mean, we've had some pretty significant outbreaks. Most often they occur in unregulated facilities, thanks to the legislature's action in the year 2000, where most pools became unregulated. That's kind of a tough thing. We don't issue fines, we don't close pools, we never have. We work with them, and we have a set of standards that's statewide to say this is how you should operate your pool facilities. That failed, it didn't get approval. So one of the conversations we'll need to have, and we'll bring some ideas back to you all in December, we can go about this at the local level, working with Mountain Home and Cascade with our aquatic center. And if we want to look at hotels and motels and gyms, which is very commonly where outbreaks occur, we'll bring some ideas forward for the board's consideration in December. And then the third, which I thought was a fascinating concept, but no doubt it needs more work, is to establish an overdose fatality review committees in each of the public health districts. And we need to get data from the coroner's offices. So Courtney Boyce was there to help with that presentation. And I know she stayed around and talked to some of the commissioners who had some opinions about that. And I had forewarned her that it's hard to get these things through at the first run, but I think she was able to learn a lot and get feedback so that, maybe there's a good way to approach this that doesn't require legislation. And I think that's what we'll be working on. And then the one position statement was to allow 39-411, which is board composition, to remain as it is. Which is the counties get to decide who they appoint to boards of health, which can include, in our case, 3 of our members are not sitting county commissioners. And there was a bill brought forward last year, House Bill, I think it was 366, that would have required board members to be county elected officials. So in the case of Ada County, I'm not sure how that would work because all three of them would be here today. And I'm certain they don't want to do that, because they're full-time, and in my 20 years, we've only had one commissioner for her one term, her 2-year term sit on the board. Other than that, it's been appointees from the community who have a sincere interest in public health, not, and county commissioners in many instances do as well. But that was an interesting conversation because we love local control, but we want the legislature to mandate that's county elected officials. And that was like a half hour of our time. I thought it'd be like 5-minute discussion.
That came out of the COVID thing.
Then you have to, if you have two, you know, if you have two or more county commissioners, then it's considered a meeting. So
Right.
so you have double meeting.
Agenda, item.
Yeah.
Our clerk would be,
Minutes.
I mean, clerks have to show up and do minutes,
Unless you send, unless
Logistic,
you send your coroner or your prosecutor or somebody.
yeah.
I think
That's
that
true.
was the second iteration
Send
of
the
that
pressure.
concept was an elected official,
So you could send a coroner.
not just a commissioner. So the commissioner thing, I think they discovered that would be really challenging. So then it changed to a county elected official, someone that the voters could throw out if they didn't like your decision on swimming pool inspections.
And who decides what county elected? I guess it would be the county commissioners, yeah. But I'm sure our assessor would love it if we said, hey, by the way, you have to go to all these meetings too.
Right. Well, I'm thinking our assessor might be the best guy. You know, not, you know, so it's, yeah, it's just, yeah, it's definitely interesting. But yeah, having the.
Any other thoughts from the last couple of days?
Yes. I was pleased to see the note on which it ended with an increased enthusiasm for public health. Because that has waned in some years, especially last year after, you know, they were saying, hey, do we disband the association? So there seemed to be some renewed enthusiasm for public health. We have to do a better job on our proxies. Our district was not well represented with proxies. So, but overall, I thought it was a good meeting. The educational day was phenomenal.
Yeah.
Jane, you were there?
Proxies did we have?
One.
Yeah, educational day was well organized, phenomenal, sad that has to be a significant topic of conversation, most certainly. But sure. Something I would like to say is for those of the CDH folks that were involved in putting it together, there were not any media glitches. All the all the video and audio worked fine. The layout was great. I think for what involvement we had in helping them pull this off, I think their logistics were
Corey was on.
really good. Yeah. Running around, making sure everything was good. So I'm thankful.
Adjusted a few times.
Right.
The thermostat.
Oh, yeah. You know, yeah, freezing, sweating.
Yeah.
Sometimes it's hard to manage temperature in events like that, but I thought our part was great in our ability to host that for them. So I'm thankful for those that had involvement in that part of it.
Mr. Chair, this was my first meeting and I really did enjoy it. I'm concerned that the executive committee calls are going to be overrun with all the members. I think that may have to be discussed in the future, that maybe not everyone can participate in those Zooms,
Right.
and maybe run it more like the IAC legislative committee, because I can imagine those calls could get derailed pretty fast. And that's why we appoint someone to the executive council, I guess.
Yeah.
I would agree.
I was hoping that was gonna get discussed a little more thoroughly, and I just want to point, my comments from Commissioner Purdy were taken out of context on her discussion with me and her comments during it. I didn't agree with her regarding the swimming pools. I'm in support of Central District Health doing it. I now have a whole new thought about going to a hotel and putting kids in a pool that isn't regulated. My point was, I don't want the county to have to take this over or food inspection. So I just wanted to clarify my comments there. I'm fully in support of the public health districts doing the swimming pools.
I'm kind of a closing comment. Sure. So, plural, is that I think to continue to advance public health, some of that work does involve policy work, and policies can definitely have a big impact on the health of our citizens broadly, not health care per se. But if most organizations and associations, just like the Idaho Association of Counties, they have a legislative committee, they have to narrow down the ideas and decide what it is they're going to take forward and advocate for in the legislature. And in our case, we have nothing. We have nothing to take forward this legislative session. We don't have IAC, although on the food fees, but that's kind of the counties have taken that on really finally. And I'm appreciative of that, but we're not going to be in an active role to help push that. And we have that knowledge because it's what we have done for over 50 years. So, you know, if I could change anything for in the future, it would be a matter of when you talk about strengthening the association, if we just meet and talk and get education and then let whatever happens happen during the legislative session, finding ourselves in kind of a defensive position, although we do that position statement will help. But I've been doing this work for about 33 years, and it's just the only time we ever had a lobbyist to help us was when we were increasing the food establishment fees, but we've never really worked on policy and what does that look like. You don't have to mandate everything, but what ideas does the body have? What, like my question after the meeting yesterday, going through the resolution process is, okay, so what do you want us to do? What do the local boards of health want from their health districts? And is there going to be consistency statewide? And that I think would be helpful in the future to talk about, even if it's not on the legislation, but what programs. You had talked about, pointed out appropriately, there's quite a conversation about healthcare and improving access to more healthcare with the really poor overall global health outcomes that we're getting. Where do we go from here? We had some very specific public swimming pools allowing minors access to consent for their own care for an infectious and communicable disease. What other big ideas do we have? And I would really like the boards to help guide that. If there's a way to engage in conversation, and we were hosting it next year, which we're not. That's what I want to design, kind of the education day around what models do work. What could we do as a state to help improve the health of our citizens? And District 2 is hosting it next year, so I won't be part of that. But we could certainly offer, even through the executive council, to have conversations about what is it that we want to do. We've added some new programs like home visiting, amazing. But as you heard from Juliet, we're now faced with potentially losing $1 million statewide, not our district. So it's like, okay, she acknowledged it's evidence-based, but that could be about 10 positions statewide. I think we have some plans in place and we're increasing our, as Laurel, not Laura, pointed out that revenue from Medicaid's really coming in well for home visiting. So that's going to offset that loss. But I'd like to see it grow. I mean, we have a waiting list for parents as teachers and not stall out the efforts we've made. But then there's the bigger stuff, what affects the community more broadly, not just the individual families or patients that we're meeting with, for example. So anyway, that's how I feel about it. I just think that as an association, the strength will be not just getting together, but what do we do to promote public health, either through policy or systems change, environmental changes? What can we do to really make a difference? And I know you all have ideas, you know, you have ideas, for sure, all of you. But really, bring them forward and have them discussed and debated and come to some decisions. You know what I mean? Like we have no resolutions other than I will go to Senator Anthony and say, yeah, did you really mean to do this? I'm not even sure we can include the whereas statements. There was chatter about, well, those are all gone now. I'm like, well, what, is there a resolution left then? Because that's what a resolution is.
Yeah, I think that ended up being resolved to ask the legislature to clarify what their intent was, because it was a little conflicting.
Right.
You know, one supersedes the other, but then the original supersedes everything else also. And typically we should have, you know, stricken what they intended to remove and not just a blanket in declaration that this is now the supreme conversation in all of Idaho code regarding the subject matter.
Yeah.
So it definitely needs to be clarified one way or another. And I think that in yesterday's action, you know, a certain guidance or inclination of which way it should be clarified was stricken along with all the supportive comments. So I think we really ended up with just a generic statement that says, legislature, please clarify, did you mean to strike that original, what section is it?
3801.
3801.
Well, and I think one of the strongest advocates for our stand on that is going to be the Attorney General's Committee on the ICAC. Because unfortunately, not every family situation is ideal. That's what's pointed out. If we don't deal with it, the problem's going to grow.
Yeah, and that was part of the conversation I had with our clinicians was when they have a young person come in, younger than 18 come in, they have conversations about their safety. And if sometimes they're accompanied, I said, well, what if you're accompanied by somebody? And they said, we figure it out. We take them to the bathroom to get a urine sample or whatever, and we'll ask the question. So we're missing that opportunity as well for kids who are being trafficked. If they ended up finding their way to us, or, I mean, it's such a tough issue. And as you pointed out, it's like, so they may be our advocate, but we don't have positions, we don't have a resolution saying that I can go talk to Commander Nick and say, hey, would you help us out here? Because we just need clarification. Is it law or is it not?
Well, as always, and I guess that comes to the executive council when there are conversations, regardless of whether or not this particular resolution has whereases and therefores on it, you know, we can still, through the council, guide the direction of and the content of legislation, clarifying legislation. You know, that option, of course, is still there. But yes, from a public health point of view, I you know, and I've been singing this tune for 30 years, you know, largely what's been going on isn't working in our nation's public health. You know, we're bringing more pharmaceuticals online, more access to pharmaceuticals. You know, almost the entire Medicare age population is on statin drug. And what do we have for it? More stroke, more heart disease. We're
Big
not,
revenue stream.
well,
There you go.
it most certainly is. And
Yeah.
if we want to increase the revenue stream, we just change from 250 to under 200. And you overnight have a new population of users. And so I think the reality is that what we have been doing as a national conversation in health isn't working. Other nations that spend far less and have far less access to modern medicine don't have the outcomes that we have, despite the trillions of dollars. And so it's very complex. It's if you start dialing into why people are really sick, it's extremely complex behavioral and marketing campaigns, and you know, the Saturday morning commercials convincing kids what breakfast cereals they need. And you know, it's just, and the differential in the number of chemicals that are in American products as opposed to European products. And you know, when you look at the TV commercials, it's almost always exposure. You know, did you drink the water at Camp Lejeune? Have you been around asbestos? Have you downwind from nuclear testing? Have you been exposed to Roundup? Have you been exposed to any myriad of things? There were families that were getting cancer at high rates because they had Lumber Liquidators flooring that was preserved with formaldehyde in there, and it was off-gassing and causing illness. You know, another exposure that was having a negative impact on human health. And until we start looking at some of those realities, I don't know that a lot is going to change.
What you're talking about, because we are still talking about resolutions or what, starting the ideas and the movement here, but then you still have to go through the other people that you were in discussion with at the meeting. So how do we find a path to make it happen?
Yeah, Mr. Chair, I think that the strengthening of the association may be, we've given a lot of thought to this. We bring resolutions forward. I think I could see people highlighting the resolutions in their packets, meaning it's probably the first time they saw them. Is there a different process we should use? Maybe it is a matter of the executive council meeting more frequently and talking about what ideas are. Betty Ann, for example, has been on the board for a while, and she understands the politics of Idaho very well. Instead of going into that room with resolutions that many people may be seeing for the first time, even though they were shared after you all approved them, I should share them out for directors and vet them through like a committee, which we have one, a representative from each of the boards, and come up with 5 or 6 resolutions that group can support and advocate for. Like, we've thought this through. We know that we think, well, there's too much opposition going to come from the hotel and motel operators. So we decided this year we're just going to reinstate the just as an example, public pools, and then maybe try to add on next year after we get the process and get the rules in place for what we had been regulating just for the last 25 years. And then have those individuals be the voice in the association to get support. I know you have the legislative committee, I guess, commissioners, to do that kind of work on behalf of the Idaho Association of Counties, instead of coming out of a meeting with nothing, you end up with, which ones are we gonna actually focus on this year? So that's a great question, and that's an idea. I mean, I think the association or the executive council can talk about that in upcoming meetings. They meet pretty frequently during the legislative session. And to your point, there's ideas out there that we could try and to work on, but we have had very few resolutions passed in the last couple of years. A lot of them got converted to position statements, which is action based, and it's not going to necessarily change anything. Maybe hold our ground with 39-411 board structure, but it's not, moving forward and advancing public health in a way. Y'all are like policymaking boards. That's part of your responsibility, and I keep saying it, we're left with not much to go on for another year. And then next year, if we have the same conversations with the same outcome, nothing's going to change.
Chair, I'm wondering if, because of this, I guess, change in dynamic or whatever, that I think, in my opinion, that maybe through the pandemic, people just have a bitter taste in their mouth and they don't want to be regulated. You know what I mean? And I think maybe people just hands off because they don't want to be, and maybe that's the attitude now. And I don't know how you change that because everybody's bitter.
Yeah.
And they just don't want public health say,
Yeah.
And I mean, that's not, what we're, in our opinion, I guess I'm wondering if this change is about at the same time.
Yeah.
Where they're just not willing to put their name on anything and dictate anything.
And I sensed that. I did yesterday. And how do you make that shift? And I do think if you're elected, which you all are, I mean, people watch how you vote with public health board meetings, I'm guessing, and when it comes time to run again, so you have to, that's not a bad thing. I mean, you want to be accountable to the people who elected you or appointed you to the board, and not everything has to be legislated, but it's like, not to bring up 39-3801 again, but I will. It's like, well, what can we do? Like, do we do parent classes, and do we, parental involvement, how to have the conversation? We do that a lot around like vaping, because parents and others you can tell the kids, wag your finger, don't do that. And we know what that results in, how responsive the kids are often. But I think parent discussions do matter, and empowering them around tough topics like nutrition and exercise and things that cause harm to them. So it doesn't just have to be policy based. I don't think policy is in laws, but initiatives. Yeah. What kind of things can we bring forward that would be palatable in our environment that, as you appropriately noted, public health worked in the background until COVID, and then we're front and center, and then we're villains.
Mr. Chair, I think that the strengthening is going to be more twofold as well. It's going to take some more activity within the association, but it's also going to take more activity and presence at the legislature. We need someone there every day, and the minimal amount that we contribute to IAC, I don't think is probably getting us where we need to be. If we really do have in the future, if there are resolutions. Sure, the food establishment fees are coming through IAC, but that's ultimately a taxpayer issue. It's not a public health. So so I think that was easy for IAC to take on because the commissioners want to recoup our fees 100%. That makes sense, but I think that's not going to be the case if it was a public health resolution. And so I think part of the executive council, that's going to have to be a discussion too on when we do have a resolution that might be controversial or may not, but we have to have the presence there.
You're 100% correct, and that's something that we haven't traditionally done, except for food fees, when it was going to generate revenue for the health district. So that but we don't have a presence. And Seth said that last year in Idaho Falls. So I work for, his responsibility is to the counties. And the counties' work is not always public health, other than the influence you all have through boards of health. So yeah, we get updates on what's happening, but there's no one there to advocate for or against things that are coming forward. So I appreciate you saying that. That's spot on. And we've had an active lobbyist, I think, twice in the last 20 years, two legislative sessions out of the last 20 years. Somebody there to listen and represent us and work on these issues. And yeah.
Mr. Chair, may I say something too? I think adding on to your comments that there are a couple different modes to take top down or kind of bottom up from budgetarily when we come together for budget revision or looking at how we spend carryover funds. If there was an initiative or a program that we wanted to start just in our district and at our level, and perhaps after a couple of years, get a success story about it that can impact policy, bring it back up to the legislature, something that we've done locally that works. That might be something to consider. I think we have, between now and next August, assuming we have a carryover balance for the board to think about, are there any programs we would want to try to stand up that might work to impact public health in our district and produce a positive result that impacts the state longer term?
Well, the conversation is changing. I mean, we started this year with the SNAP bill.
Mhm.
We're not paying for soda and, Krispy Kreme under the SNAP program any longer. And now in Washington, they were looking for states to ask for the waiver. And in the past, we've been beholden to the beverage industry, right? And we haven't been able to make these moves in things that'll ultimately improve public health. I mean, here we are, subsidizing non-nutritious food in a program with nutrition in the title, and then dealing with the ramifications of it through Medicaid. So we're paying for the problem to create the problem, then we're paying to have weak attempts at solving the problem. And so there is a different conversation going on, but I look like new programs. Everyone that walks in the clinic should have a vitamin D test and get supplemental vitamin D. The data is unequivocal. 750,000 individual study out of the VA post-COVID. And in a nutshell, the higher the vitamin D serum level or the higher the vitamin D supplementation, the lower the morbidity and mortality of COVID. And some of us do that. I mean, that's the research that's been in existence for decades, but we've had to buck the trend. And if we want, programs that actually impact public health, it's educating people to those ends. Now, gotta fight all the commercials on TV and gotta really flip a switch, but there are things that could and do, make a huge impact in public health. And in my profession, we've known that for decades, and most of us are living it, right? Sounds weird, but the only day in 31 years in my office I missed was the day I knocked myself goofy snowboarding for the day after. So there are ways of practicing what the actual science says and having outcomes that actually are beneficial to public health. But the question is, how do you actually institutionalize that over the lobbying efforts and resources of people that have products and thoughts in contradiction to what we know actually works.
Well, and you say bringing this down to a local level when we've got the Washington lobbies for our sugar industry, our grain industry, and you look at where the subsidies go for our food. You know,
They go right to the food triangle.
and, you know, the same thing with Big Pharma.
Yeah.
So it's hard to
Didn't it
dial that
surprise-
down.
Does it surprise you that Twizzlers are still allowed under SNAP?
Well, and as I look at the WIC, the qualified WIC foods, you know,
Yeah.
I looked at that, some very high sugar things.
But they,
Right, yeah.
and some were opposed to that bill because of the definitional challenges like that. You know, how do you,
With the flour content?
yeah, there were, you know, somewhat arbitrary decisions. You know, or amounts of this or that, like flour, that then took something out of the restricted category. And could that have been refined a lot better, literally, figuratively? Probably, but my opinion was it was a start.
It is definitely.
So,
Yeah. Well, and you know, getting back to the flour thing, the flour of today is not the flour of 50 years ago.
No.
We have gone for shorter straws, higher production, and that subsidy comes into play. So
It's great.
yeah, but it's great.
How much are you talking when you talk about, being a lobbyist? Like how many dollars are we talking over a year's time or whatever? What is that?
Mr. Chair. About $15,000 for the lobbyists we had used, which has been Mike Kane. So it's a little over $2,000 per health district. So
Do
it's,
you think what, do you think you've got what you wanted for that amount?
the years we used them for the food establishment fees, both times, they were separated by close to 10 years. We were successful in increasing the food establishment license fees, which was a big deal because increasing fees in Idaho is not, for a governmental entity, is not an easy task. So I think most organizations that pay lobbyists pay, I mean, I hear, you know, $100,000, and they tend to work more year round. We didn't. It was kind of like legislative session, so it's 3 months, about $5,000 a month. What we paid. So
Can
pretty,
it go directly from here to the lobbyist, or does it have to go through the? I mean, do we have to sell it to the association first?
Through the
or do we-
it went through the association's budget, so District 2 manages that. So District 2 got the invoices and paid Kane and Associates to do that work.
But we
The
had talked
idea.
about going from our district to the lobbyist directly.
Yeah.
Yes.
And
Yeah. Oh, yeah.
Yeah.
the question would be, you know, what do you want to accomplish? You know, is it a monitoring and then a reaction, or is there a certain policy that
Right.
we want hammered through the legislative process in a given session? And that's going to dictate cost also.
but directly, couldn't we accomplish part of what you were talking about, Laurel, of doing something to show and then have the proof that we're coming back to sell outcomes?
I think that, Mr. Chair.
Well, some of the policies, I think we have the authority to implement on our own.
Yeah.
You know, we're not restricted legislatively, I don't think, on a broad thing. I mean, we could try our own internal policy and it wouldn't require lobbying. We could just find it and do it. Maybe some things where we're statutorily required like to provide SNAP benefits or, you know, I got laughed at when I brought up restricting SNAP benefits 4 years ago in the Health and Welfare Committee. Well, now we're not precluded from doing that. So unless it's a specific exclusion, I think we have the authority to test the waters and not require legislative action, lobbyists or anything, just money to do something out of the box.
Mr. Chair, I know in Elmer County, we're kind of burdened with our suicide issue and teens and stuff, so that might be something to pump money into for at least our health district or something. I know that's it's hard in our county. And there's really not a lot of initiative. You know, there's not a lot of to be a head runner on something like that, but you know.
Mr. Chair, we have right now like one partial part-time FTE that manages our suicide prevention program in Curtis's division, but that's a program we've talked internally about beefing up, and that is something the board could easily direct funds towards. I know it's not as simple as hiring another position or something like that, but if we wanted to talk through what a program might look like, what each county needs and stand it up in a way that our district can support, that's something that already flows into what we do. We could just look at how to expand it effectively with board's consultation and support.
I think those outcomes can be worth it, you know, as far as improvement.
Interestingly, back to my thing, nutrition or the lack of proper nutrition actually can have a significant impact on mental health, right? And so, you know, if you're looking at things from a human health point of view, the more you distill it down to the basics, generally, the better the outcomes, and you're going to start having an effect on multiple other issues if you're dealing with the core nutrition and fitness. And
I see it daily in my business that we have something kids that only 2 bring homemade meals to lunch. One of those is Singaporean.
only
Two,
bring
everything
homemade
else
meals.
is packaged.
In Lunchables or. Mhm. And, you know, from a healthcare economics and political point of view, you know, there's a lot of resistance to doing comparative studies, right? I mean, the reality is there's a real objection to doing, you know, vaxxed versus non-vaxxed, you know, home birth versus hospital birth, all these different types of comparisons. If you're have a certain mindset, you don't want to see those done because the outcome might not be in your favor. And so there's huge campaigns to prevent that type of exploration, scientific exploration. Should we wrap this conversation up?
Food for thought. Yeah.
Food for thought,
Food for thought.
as long as it's healthy food for thought. So any final comments, board members? Okay, next item on the agenda. We are nearly 30 minutes ahead. Does anybody need to take a very brief break, or should we charge into executive session?
Charge in.
Charge in? All right, so, I'm sorry. This will just need to get into executive session.
I would move that we enter into executive session under Idaho Code 74-201B.
Are we on track with her making the motion, or Was I supposed to go through this?
You need to go through that first part, then we can.
Oh.
Sorry.
Okay, no, that's fine. I'm not used to this part of it myself, so, at this time, we will call for a motion to go into executive session under Idaho code. Once the motion is approved, all non-board members are required to leave the meeting unless they are asked to stay or called into the meeting by the board during the time. Non-board members will be invited back after the board returns to regular business meeting. Now I would call for a motion to enter into executive session.
I move that we enter into executive session under Idaho Code 74-2061B.
Second that motion.
Okay, then, all in favor of entering into executive sessions? Aye. Aye.
So, yeah.
Oh, you have to.
Yeah.
That's part of it.
It's by rule.
Yeah.
Okay,
Yeah.
so do you want to call the roll?
Oh, yeah, Dr. Jane Young, Ada County,
Aye.
Commissioner Chris Rogers, Elmore County,
Aye.
Dan Middleton, Elmore County,
I,
Commissioner Connell Caldwell, Valley County,
Aye.
and Dr. Greg Furch, Ada County.
Aye.
She has board entered executive session at 9:56 a.m.
Right, very good. Central District Health Board is coming out of executive session. And
And I'll make a motion to increase the director salary in line with what we did district-wide, as far as increases go, as well as the retention bonus.
we have a motion. You got it? Are we?
Yes,
off?
okay, so do we know the exact numbers? I apologize, Mr. Chair, like what are we follow?
No, we don't have to have those exact numbers, I don't think, do
Or
we?
like the percentage?
Do we kind of talked with Gary about it. Do we need to do that? Or-
We can just put it in then.
It was the same policy that we implemented,
Sounds good.
right? So that's your motion. Second. Oh, any discussion on, public discussion on the motion?
I think it's important just to say thanks to the director for his work.
Right.
Very good. Thank you, Russ.
Yeah.
All in favor of the motion, say aye.
I,
Aye. Any opposed? Okay, motion carries.
okay. And I would like to add, thank you to all of you guys and welcome. Thank you.
So, very good. That concludes our business for today. Any final comments from any of the board members?
Happy Thanksgiving. We won't see you till December.
Very good. All right, with that, we're adjourned.
Oh, and we need everybody's evaluation board back for me.
File's good.
I don't know what happened in my mailbox.
Oh, of course.
Well, yes, that's in there.